in adults. And interestingly, there's a group that actually starts for the first time after 60 years of age. In the older literature, it used to say 1 to 3% in adults. Now it says 7.2% from more recent figures that are probably more accurate. But as you can see from this figure, so many start early on and then do go away, particularly, and this is what I see too, particularly around 3 to 5 years of age, a lot of it clears. And then there are others that actually don't even start until that time. So a wide variability in terms of the time of onset. Overall, a 10 to 18% prevalence in children. And what I want to also show you on the left is the severity. So the vast majority, and what you primarily see, is mild atopic dermatitis, about 67%. We don't get to severe until we get to about 7%. Now that's in children. As we go up in age, we go to adolescents, we're now talking about 40%, not 33%, that have moderate to severe, and it can be almost 50% by the time we get to adults. Now, I don't have to tell you about the many impacts of pediatric atopic dermatitis. You know it all. You know that there's this terrible itch that's a characteristic of the atopic dermatitis, and that tends to lead to sleep disturbance, not just problems falling asleep, but frequent night awakenings. We also know in the young children, co-sleeping is a real problem. We have disease exacerbations, and it's particularly during those times that we see problems with school productivity. But there's also a lot of stigma associated with atopic dermatitis, it being highly visible, the patients scratching all the time, the issues with not being able to do everything that the other kids can do, looking different, and psychosocial development can be impacted with a high frequency of bullying. Now, many of these individuals have comorbidity, skin infections, not uncommon, particularly with moderate to severe disease. And of course, there are the other atopic disorders, very high risk of having another form of atopy, especially with moderate to severe disease, but even with mild disease. And you can have severe asthma, for example, with mild atopic dermatitis. And then, of course, mental health considerations, because this has to lead to some problems for some kids, and it does. Increased risk of anxiety, depression. There's actually an increased risk of attention deficit disorder in this group as well, which I think is fascinating. It's unclear if it just reflects the early sleep deprivation or if truly the cause and the cytokines that are involved with the immune shifts in this disease also cause problems that affect the development of the brain. And then all of this eventuates in impaired quality of life, with daily activities, social functioning, and life course decisions, and can affect the entire family. So sets the stage. It's what we all see. And just to update you on what is going on that underlies atopic dermatitis, it's very complex. And we used to talk about what comes first, but nobody bothers with that anymore, because we know that the barrier function, the abnormal immune responses are all very much interlinked. If you have one, the other gets worse. And these various barrier function and immune responses do reflect some underlying genetic predispositions. And then we throw on top of that a wide variety of environmental and climate factors, as well as the microbes on the skin that can trigger the responses, and it makes atopic dermatitis. Now, this is a little bit of a complex picture, but I'm just going to walk you through for a minute, and then we'll get on to therapy. And this is just reminding you, if you look up at the upper left, it talks about some of the aspects of the barrier disruption. You've heard about filaggrin, high risk of also having a deficiency of filaggrin, which is seen with the disorder ichthyosis vulgaris, which so many people haven't heard of, but is the most common genetic skin problem. 10% of the population carries one of the genes that reflects a deficiency in being able to produce this, and it gives one dry skin and particularly dry legs in the winter, with hyperlinearity of the palms, so common in atopic dermatitis and the major risk factor. But just from having atopic dermatitis and the immune shifts, you have a reduction in not only filaggrin, but a wide variety of other barrier proteins and lipids that are so important between the skin cells that make up the barrier. And then the other thing that we can sometimes see, we did not find it so much in kids, but certainly there, as you get older, is a reduced ability to mount a normal response to organisms with antimicrobial peptides. it's not just the barrier disruption, but then what happens to the immune system. And the immune system here includes dendritic cells, like that Langerhans cell with all its arms there in purple sitting in the epidermis, and also the keratinocytes, or the epidermal cells themselves, because they are sensor cells and they sense the allergens, the pathogens, the irritants, the toxins, and have dramatic results. Usually, for those of us with healthy skin, our Langerhans cells only reach up to the upper part of the epidermis and don't go beyond what's called the tight junction region, which is very important for water retention. But when you have an impairment in the barrier, the Langerhans cells are actually, you can actually see them just stretch all the way up virtually to the surface and really sense. And then the skin cells themselves do a lot of sensing with what are called alarmins, and that just activates the whole type 2 immune process, which is what many of these other cells are shown here with the group 2 innate lymphoid cells and Th2 cell. At any rate, we get down to a lot of particularly interleukin 13, which we now think is central to atopic dermatitis. And then there are a variety of these other cytokines and chemokines that lead to thickening of the skin and a variety of other issues. I'm showing you here a nerve because we're learning a lot more about the relationship between the immune system and nerves, but suffice it to say that there are all kinds of receptors on the dorsal root ganglia that stretch all the way from the spinal cord out to the skin that are activated by what's going on with atopic dermatitis. In the lower right-hand corner, you'll also see what's called JAK-STAT signaling, and that's important to know about. That is downstream of the receptors for the various cytokines that are activated here in atopic dermatitis, and is another potential target for therapy. I'm going to talk about therapy and tell you that there are new guidelines now specifically for pediatric atopic dermatitis being made, but previous guidelines were not very pediatric specific. Nevertheless, when you put them all together, and I want to spend most of our time here just talking about this, which is the yardstick or stepwise approach to care. Everybody starts with basic management. So of course you all know that skin care makes a big difference. It's not going to take away the inflammation, but we really need to make sure that the shower bath isn't too hot or too long, and that the moisturizing occurs right after. And probably the biggest problem that I see is people who buy moisturizers that have things in them that they shouldn't be using. Of course, fragrance-free, but then there are all of these quote-unquote naturals. The last thing you want to do is put on a moisturizer or anything that has a lot of these vegetable-based herbs, because they are some of the most common sensitizers we're seeing right now. So keep it simple. Trigger avoidance, of course, very important, and considering the comorbidities, including allergic comorbidities, infections, etc. So as we get into mild, we usually treat this just with intermittent topical steroids, but we do have non-steroidal alternatives to consider. The topical calcineurin inhibitors, that's tacrolimus and pimecrolimus, the new Chrisaboro, and then the newest JAK inhibitor, ruxolitinib, that just came out. With mild disease, for the most part, we can do the basic with the skin care and the trigger avoidance, and then we can treat with usually just a topical corticosteroid. And if it weren't for the steroid phobia, that would probably be just fine, because we're just treating intermittently and at localized areas. When we start to get more severe, to the point that you're not just able to just treat for a few days here and there intermittently, and you're going to more moderate disease that's either more widespread or certainly more intense and needs something more chronically, then it becomes really more of an art, I think, to juggle it. You can get anybody under control pretty much with hitting them hard with a topical steroid. And one of my most important messages is not to be worried about treating for a week or two aggressively to get something under control. I've been doing that for 40 years. I've never seen a patient who had a problem with that. So I know somebody asked, what's my favorite topical steroid? I use a lot of mometasone ointment. It's strong. It's not hydrocortisone. In fact, it's a little more potent than the triamcinolone 0.1% that we all use so often as well. But I find, I don't care if it's a baby that comes in who has moderate to severe disease, I'm going to start with mometasone and I'm going to hit them hard. In fact, I'll often say, I want you to treat for 2 weeks. It might look better in 3 days, but I want you to treat for 2 weeks and really knock this out. And what we do is we put a thin amount on twice a day. On the face, I might even treat on the face with mometasone, but just for a few days, and then I'll move to something else. So the idea is to hit hard and then figure out for that particular patient what maintenance will be. And maintenance is really where the art is, because we can get things under control, but how do you safely maintain? I'm certainly not going to continue mometasone twice a day if I can help it in a child. But of course, some of the most severe cases, we do have to think about doing that. I'll talk about that in just a minute. So there are alternatives to maintaining. I might hit hard, I get something under control, and then I do what I call dialing down. So I might go down to once a day of the mometasone for a week. And then depending on what's going on, it may be that we find that things start to flare, or it might start to flare in certain areas. If you can get to something called proactive management that I'll talk about in a minute, that's the best for some of these more severely affected kids, because then you can do something 2 or 3 times a week with a medium to stronger steroid, or going to something like a tacrolimus ointment, and that works pretty well. I'll talk about that in a minute, but dialing down to something that's either intermittent, like 2 to 3 times per week, or dialing down to a lower strength, or best of all, I think dialing down to something that doesn't even have any topical corticosteroids, so you can go back and hit hard again if there's a flare and keep it going for a few days past the flare, or you can hopefully keep things under better control by intermittently every few days putting on something that keeps the inflammation suppressed. Now, I'm not going to say too much about severe disease, but I will mention that we have to consider when is it a time to go to systemic therapy. And at the bottom, I've listed some of the things to keep in mind. First of all, there's a lot of steroid phobia out there. There's phobias about the black box and topical calcineurin inhibitors. So there are people who either for that reason, or maybe they just don't have time, or the regimen's too complicated, are non-adherent. A long list of potential reasons, but that's always the first thing to consider when someone's not doing well. We need to look for infections, whether we're talking about staphylococcal infections or herpes infections, and get those treated. Misdiagnosis, not too common with atopic dermatitis, but it can happen. And another reason that's very clear for some people for not being able to clear is that they have contact allergy to medications, or even just to the emollient base. I mentioned before all the sensitizers that are in some of these topical products. I never hesitate to refer. If you ever want to refer to me, by the way, email me. I will get somebody in very quickly, like within the next few weeks, not 6 months later. Okay, I do want to say a little bit about the boxed warning for tacrolimus and pimecrolimus, that's Protopic and Elidil, and tell you that never should have been there in the first place. But here's a study we just put out with the 10-year Apple study results that showed not any evidence of lymphoma or non-melanoma skin cancer, no increased risk of cancers at all. There have been several of these papers. Here's another one in adults showing no evidence of keratinocyte carcinoma, the basal cell or squamous cell carcinomas, and another one from Europe that came out a few years before. And because of the one from Europe and the one we just put out, Canada just reversed its box warning for tacrolimus. And I hope that the FDA will consider doing this, because it was really a problem for our patients that this warning has been there in the first place. This has been really a workhorse for me in terms of getting kids off of steroids. Let me stay on this for 1 minute to just say, by the way, even though it's generic now, it still can be expensive for families to get the tacrolimus, which I use quite a bit. You can get a 0.1% tacrolimus at Mariano for $38 for a 30-gram size with a prescription. It doesn't have to be expensive. I hope you're familiar with goodrx.com. It tells you how much things are at different places. And I just routinely will say to a patient, if it costs you more than $38 with insurance, just have them send it over to Mariano's, pick it up for $38. And if I want to give a 0.03% tacrolimus instead of 0.1%, then I'll just say, and you can take in your hand and take 2 parts of Vaseline and 1 part of the medicine, mix it up, and you got a 0.03. So very cost effective for families. I want to tell you about proactive approach, and then I know we're so short on time, I'm going to run through the rest really quickly. Proactive approach is what many of us use when there are certain areas that will reflare if we stop the topical corticosteroids, often the antecubital, popliteal areas, sometimes more extensive, but this is the proactive approach where you get it under control, let's say with the mometasone ointment, you dial it down, and then you get it to once a day for a week. It stays clear, and then just in those areas where it will recurrently flare, even though they look clear or almost clear, we're treating. And we can be treating here with a topical steroid like mometasone or triamcinolone, 0.1%, or we can use something like the tacrolimus and just use that if you want to get away from steroid altogether, which a lot of families like. I'm going to say a little bit about Chrisaboro. It's new on the market from the last few years. And I know there are a lot of questions about it. It looked okay in the trials, certainly looked safe, showed effectiveness in mild to moderate disease, and really didn't show much stinging and burning. That was not the case when we started using it. I saw a lot of stinging and burning with the Chrisaboro, and I have to tell you, I don't use it very much, but it certainly is on my list of potential alternatives. I find it particularly stings and burns on the face, and more so than what I was seeing with pimecrolimus or tacrolimus. It is now, however, approved for infants as young as 3 months of age based on this open label trial and the results that we're seeing here showing a good effect. And of course, there were low levels of burning and stinging because when you're less than 2 years of age, you don't really talk too much about how things feel. But nevertheless, it is out there. So if I don't want to do a topical steroid, if I'm talking about something for the face, I might try the topical calcineurin inhibitors. I might try this. Or the other new one on the block is the topical ruxolitinib cream that just came out in September on label for 12 and above, and that's getting those JAK inhibit, the JAK-STAT pathway that's downstream of these various receptors like IL-13 that drive atopic dermatitis, or IL-31 that we think is very important for the itch. And I'll just show you, if you look at all these green and blue bars, it just shows you what was just reported in the studies of adolescents and adults with really a great effect on everything, including very fast responses on the itch. I think this is going to be really key for our patients with atopic dermatitis. It's really expensive. If you just buy the tube, I've heard it's $2,000, but you can get it for $20 if you have insurance. And I'm just waiting now for our Medicaid covered patients to be able to get this as well, but haven't had a lot of experience because it just came out on the market, but in studies it looked really fantastic. And these are the studies for the adolescents, same kind of thing. As you can see, clear, almost clear over the 8-week period in the majority of patients with dramatic responses, including very fast responses on itch. Safety is good. There hasn't been application site burning. In fact, much more in the vehicle than in the medication itself. These are long-term data showing about 75 to 80% response in patients on these trials treated with the 1.5% formulation that's come out. 52-week safety results look great as well. And I'm just going to tell you that the trials are now in progress for 2 to 11-year-olds. But of course, it's on the market, so you might be able to get it to try. I have a lot more here, but I know that, can I go for another few minutes and then take questions for those who want to stay? Is that okay?
I think that's just fine. Thank you, Dr.
Okay.
Kelly.
I'm going fast, as you can hear. I want to just let you know what's coming out. So there's a lot of great topicals now. And so we have choices, but there are more coming out. The Chrisaboro is a phosphodiesterase 4 inhibitor. It works as an anti-inflammatory, and it's just the first. There's another one called Roflumilast that is much stronger, and in trials does not seem to have the burning or stinging that we've seen in Chrisaboro. Of course, we didn't really see that in the trials, so remains to be seen, but it really looks like quite a good medication's being looked at, not just for atopic dermatitis, but psoriasis as well. There's a whole new class called the Therapeutic aryl hydrocarbon modulating agents, or TAMAs. And the first of these is called tapinarof, which antagonizes a receptor that sits in the skin cells called aryl hydrocarbon. I'm sorry, it's an agonist of that. It's a little bit complex, but it actually, through stimulating this receptor, seems to improve the barrier, reduce inflammation, improve the handling of microbes, and actually also decrease itch because of its pathway that affects something called TRPV1, which is a receptor on the nerves that is very important for the itch response. And so far, it's also not shown any stinging and burning in trials. Some patients, interestingly, have had folliculitis, but that, of course, is easy to treat. And then one I'm kind of excited about too, and that is using the commensal bacteria as therapy. It's been shown that not only do patients with atopic dermatitis, particularly during flares, have an increase in Staph aureus, but they also have a reduction in those commensal organisms that we know also can kill Staph aureus and keep those numbers down. And there is a commensal called Staph hominis, which now has been shown in some early phase 1 trials in adults to look quite safe and to really have a good effect on patients. So more to be seen, but keep your eye on that as well. Unfortunately, other than maybe if you start prenatally with probiotics and continue them through the first 6 months and prevent atopic dermatitis, really we haven't seen that any prebiotic or probiotic manipulations have done much for controlling atopic dermatitis, although it's clear that combinations of probiotic organisms would be necessary for best effects. I'm going to skip this. It's just kind of going through what I went through before about optimizing education, optimizing the topicals, and considering other possible things that might be going on, like a comorbidity, before you get to systemic therapy. Someone did ask, I know, about wet wraps, and we do use wet wraps for our patients. You can do wet wraps by either taking like Long John-like pajamas and getting them moist and putting that on as a first layer and then another layer over it. The wetness and the coolness soothes the inflammation, and it certainly can be helpful when people are having flares. The problem with it is it's not very comfortable to sleep in something that's wet. So for kids who can do that with either wrapping with wet gauze or putting on the relatively tight, thin pajamas, if you can do that, if a parent can enforce that, I think it's very helpful. But a lot of the kids, especially once they get beyond the first few years and they can take off things, don't like to have that on. So for a lot of my patients, if I'm trying to do that, I'll do that, for example, in the evening for a few hours and just push things forward if they don't want to sleep in it, and it can be helpful. So systemics, I'm just going to say, are favored in the past has been cyclosporin for a few months, get things under control, move to methotrexate. We use low-dose methotrexate, and it worked pretty well for many patients, but we've changed that all because of Dupilumab. Dupilumab came on the market even for 6 to 11-year-olds just a little more than a year ago, and has really, as one parent said, been a game changer for these kids. In the adolescent group, in the 6 to 11-year-old group, I'm just showing you some of the data here in terms of, on the left, what you're seeing is the proportion of patients who've achieved a clear or almost clear status. On the right, for each of these sets, who've had a 75% reduction in what's called the Eczema Area and Severity Index. So beautiful results with either dose separating out from the placebo effect. And the beauty of this is there is weight-based dosing as shown here. But the most important thing is that it really doesn't have side effects. So yes, some people have some injection site reactions, low risk of that, and tends to be usually pretty mild if it happens at all. I get very few of those. Conjunctivitis is what we talk about. So in the trials, about 5% on placebo versus 10% had this conjunctivitis. You usually can treat through it. I actually haven't even seen it in anyone that I've started who are children, and particularly I do tell them, put some drops in, because we know what happens is a reduction in goblet cells that lubricate the eye in the first months. And so if you lubricate the eye, I think that can be very helpful. And again, very low risk, but reduction in skin infections, improvement in the skin. And this also is going to be out pretty soon for 6 months and above. The phase 3 trials were completed, same safety, same efficacy. and doesn't suppress the immune system. It's suppressing type 2 reactions, which we don't think are really important for anything except parasites. So we're really excited to have it. Doesn't work in everybody, but it's certainly my go-to. Probably the biggest downside of it, it's an injection. But fortunately for the younger kids, it's only every 4 weeks. So there are some emerging biologics. I'll just show them here. Tralokinumab is now available already in Europe, but hasn't come yet to the United States, and lebrikizumab is still in trials, including in children. These are both targeting interleukin-13 itself in somewhat different ways. Nemolizumab is something that targets the interleukin-31 receptor. Interleukin-31 is the itch-specific cytokine. And so I'm not sure where that's going to play a role, because we have so many good agents coming out that I think work better on the inflammation as well as the itch, but it's there. And then finally, the oral medicines. These are the JAK kinase inhibitors, and they are coming, but I'm not sure about their role for pediatrics, because these aren't the topical ones I'm talking about now, because when you have a topical, you have safety. Topical isn't getting into the circulation. It's not having any systemic effects. That's what we're worrying about with the JAK kinase inhibitors. These have a broader immune effect, including on the interleukin-31 itch, but orally, so you can take it once daily, rapidly cleared, easy stop and start. So for someone who has more intermittent bad flares, maybe it's a good option. It also works very well for many patients who have the hair disorder alopecia areata or alopecia totalis universalis. And I think if I had somebody who had both bad eczema and that, I might consider this, because you're getting you're hitting 2 disorders at the same time. There are some that are fairly selective for JAK1, which is the common JAK that is involved in atopic dermatitis. One is upadacitinib, one is abrocitinib. They are highly efficacious, even a little bit more than Dupilumab at their highest doses in adolescent and adult trials. Again, still not on the market. Baricitinib is a little bit less effective, but as you know, is already on the market for rheumatoid arthritis, and also currently in trials. This is the big thing, it's the safety. There will be a black box. By the way, there's a black box on the topical one, even though there's not even any evidence that topical ruxolitinib has safety concerns at all that people worry about. There is a black box because the FDA is conservative and they put it on there. Think about the black box for tacrolimus and pimecrolimus. So certainly the orals will have a black box. There's nausea and vomiting, particularly with the one called abrocitinib. There's a more acne with the one called upadacitinib. There are increases in the risk of particularly herpes zoster, and there are some lab abnormalities, although none of them have been clinically meaningful for patients. However, what everybody worries about is what we keep hearing about with tofacitinib or Xeljanz, and that is increased risk of malignancy, increased risk of thromboembolism, increased risk of infections. These have not been seen in any of the trials for atopic dermatitis, but we have to be thinking about them. We don't know if some of these more targeted ones that are coming out now for atopic dermatitis don't have these risks, or how high the risk is, but we're all pediatricians. We know that if we're trying to treat kids, safety is of paramount importance. So I just wanted to bring that up. And I think I'm going to skip this for time's sake and just end so that we have a little bit of time for questions. If I can figure out how to get this off, you can start asking questions. Somebody tell me how to stop sharing screen.
Oh, okay, I can take your screen, Dr. Paler.
Okay, thanks.
So.
Okay, so happy to ask any questions that you have. It's pretty tight to squeeze that into about 15, 20 minutes, but I tried.
Yes. Thank you for able wrapping all that up so very quickly. We do have time for a few questions right now. We do have Dr. Lochter had sent a question. You did discuss this, touch on it a little bit, but can you give some instances in when you prefer to use non-steroidal topical treatment?
Well, certainly for sensitive areas, the face and the groin, it's my treatment of choice. And could you do me a favor, by the way? I actually forgot I wanted to show everybody something else. Can I just put I'm going to put it up again.
Sure, I will get that right over.
If you can do that, I just want to tell people about some opportunities for patients that I forgot. So I'm a big proponent of it. I have some patients who never use topical steroids again because they're using the there we go. I just gonna put up something for you. There we go. I want to tell people about some studies. I'm just going to leave this up here to mention that, including for patients that I see in Northbrook, which I know is more convenient for you, we're doing some pretty cool studies. One is I give free closeout to infants and toddlers. We've had this study going for a while. It'll go for a while, where this is made of this fantastic fine merino wool. And I know that sounds terrible. We say, wool, we're staying away from that. But this is incredibly soft, and our families with atopic dermatitis have loved this, and we can see people at Northbrook for this. If you have anybody with mild to severe atopic dermatitis, 3 months to 5 years of age, certainly can let me know. We're also doing studies with some of these agents I talked about, the ruxolitinib cream, the tapinarof cream, these new medicines coming out for your steroid phobic families who might want to be in a trial. One of these is for moderate to severe. The other is for mild and up. You can take a look at this while I'm answering questions, and anybody can just email me. Give a patient my email. I am fine with that. I don't have a problem. And I'll put up in a minute the QR code and numbers directly for our study unit for anybody who's interested. But I'm happy to have a patient just come in of yours. I don't even need to take care of their eczema, although we can give them some tips while they're at it. Who might want to try the clothing study, for example. It's a great opportunity. So I use the nonsteroidals quite a bit for any family that has steroid phobia. If I'm going to need to treat on the face with any chronicity, and I also like to use it, or at least try it, for anybody who's going to have some chronicity, or I'm going to have to use topical steroids regularly, even if it's just localized to, for example, antecubital and popliteal areas. It's really been a workhorse for me for many years, and I put that whole group of non-steroidals into it, not just the tacrolimus and the pimecrolimus, but really all of them, whichever works for the patient. And you know, even the Chrisaboro, Eucrisa, I may find that it burns and stings, but it's still it's a good medication, and it doesn't mean you can't try it in somebody and see. There are many people who use it, and there's some reports too that it might be helpful for hand dermatitis. So I'm not being negative about it. I'm just saying my own experience. I was somewhat disappointed just because of that. But I have no problem, particularly around the eyes. I do not like to use steroids at all around the eyes, and I don't want people just to have to use the bland moisturizer. So that's a good place. But I'm going to make something very clear, and if I had an hour, I would tell you all of this within it. And that is that all of these non-steroidals that are out so far, perhaps not the ruxolitinib, but the tacrolimus, the pimecrolimus, the Chrisaboro, they can burn and sting. And some tips to reducing that risk are: number one, go ahead and treat with a topical steroid for a day or two, bring down the redness first, and then move to the non-steroidal to continue the job more as a maintenance type. Don't try to treat when there's a flare, because the greater the inflammation, the greater the risk. A 0.1% tacrolimus, rather, much more effective than the 0.03%, and some kids need that, some kids don't, but also will have an increased risk of the burning and stinging. Other thing that we can do is keep the tube in the refrigerator, keep it cold, or chill the skin that you're treating itself with a little cold water first and then put it on. Those are other clues that will decrease the burning and stinging. Probably with all these drugs, although they've never looked for Chrisaboro, with all these drugs, it is because they also stimulate that TRPV1 receptor towards itch that I mentioned, actually being reversed with the new tapinarof drug. At any rate, they stimulate that, and that's the same receptor on the dorsal root ganglia that is stimulated with hot chili peppers, with capsaicin. So that's why you can feel a sense of stinging or a sense of warmth. And actually, if you just keep using it for a few days, it doesn't happen anymore. You get used to it, just like if you keep eating chili peppers, you don't taste it anymore. So I think that covered that.
Okay, thank you. I know I just want to be conscious of everybody's time. Thank you for putting the QR code up, Dr. Paller.
Yeah, just take a picture of that, and you can just check out if you want to say, hey, what's Dr. Paller doing in terms of studies? Because we've always got studies, including for some of the systemics. You can just check out and see what we're doing.
Thank you. We have recorded this session. I know she jammed in a lot of information, super helpful information. So please feel free, Pediatrust providers, to review this at your leisure and share it amongst your group. So I think we're going to leave this up to Dr. Rucoba to see if we need to have a visit to allow for more time of question and answer, because I think we have gone a little bit beyond our 30 minutes, but I appreciate everybody's time.
And I'm sorry for the early problems getting on. My email is here too. And again, you can email me anytime about a patient and then have the patient send a note to me. I'm just so happy to see anybody who has eczema or psoriasis or any of these problems that make them uncomfortable.
Excellent. Thank you. And just a quick note, Dr. Paler, you prefer the Northwestern email rather than your Lurie email address?
My Lurie email comes into my Northwestern email because I have so many different emails, but then I can't reply to you because it looks like I'm just coming from it doesn't get back to you. So if you use the Lurie email, that is fine. Or if you want to send me a note in Epic, I check it every few days at least.
Okay.
Those are fine too, but do be aware that if you send something to my apaler@luriechildrens.org, I won't be able to reply unless you have your email in there and I can see it.
Okay. All right. Thank you for clarifying that. All right, Pediatrust providers, thanks again for all of your time this morning, especially for your patience in getting started. And we would be more than happy to talk with your group again. So I hope you all enjoy your day and stay tuned for the recording. I'll probably just be sending that to Dr. Rucoba for him to distribute to all of you. So thank you and have a great day.
Thanks, everybody.
Julie, if I may, real quick.
Thank you,
Julie.
Julie.
For our Pediatrust folks, thank you. This is Chad Worley. I just want to remind you that we are having a infectious disease talk next week on December 8th. So I hope you could join us for that. You'll be receiving a link from us for that as well. And we just want to remind you that how much we value the Pediatrust relationship with Lurie Children's. And please reach out to Julie or myself for any of your needs with Lurie Children's.
Thanks. Bye.
Thanks.
Thank you.
Thank you.
Thank you for your time.
Thank you.